test your, as you study, you can test yourself and know your progress. So we offer you 3 subscription plans. One is basic, standard, and other mentorship. Mentorship is a wholesome program which we offer you at a special discount rate of 50,000. Okay, you can also use the coupon code Dr. Divya 20 for discount on the subscription also. And in this mentorship program, in addition to the pre-recorded classes, live doubt clearance, we also offer you one-to-one personalized guidance as well as notes. So you can book a slot for personalized counseling session using the code for the first paid live class. And about this internal exam marathon classes, which you have started from April 22nd, it's for duration of 45 days, where we do rapid revision of all the important questions asked in university exams. We do a quick revision of some of the volatile facts, as well as multiple choice questions would be covered here. So this is beneficial for everyone of all the students appearing for different university exams. So when you do these revisions, we assure you top-notch grades in your exams too. So with this, we begin with today's classes. So abdomen and pelvis marathon session 4. So here today, we will be dealing with some of the very important questions that are commonly asked. One is the inferior surface of the liver, the features of the inferior surface, then extrahepatic biliary apparatus, where we include gallbladder also in a little bit in detail, and then about kidney. And short answers will be dealing with development of kidney as well as derivatives of mesonephric and paramesonephric duct. So we shall begin with the essay questions. So first is the inferior surface of the liver. So here you need to know the features, what are the peritoneal relations there, the porta hepatis, which is present there, and the bare area of the liver, as well as the true and false ligaments of the liver there. So when we say the inferior surface is also called as the visceral surface of the liver. Okay, so because most of the viscera come in relation with the surface of the liver. So it is separated from the anterior and the right lateral surfaces by the sharp, this is the inferior border. Okay, so this inferior border, it separates this inferior surface of the liver or the visceral surface of the liver from the anterior as well as from the right lateral surface. So most of this inferior surface is covered with peritoneum except 3 areas. One is the fissure for the ligamentum venosum, the fissure for the, this is ligamentum teres, the porta hepatis, okay, and the fossa for the gallbladder, okay. So here the fissure for the ligamentum teres, this is the ligamentum teres here, okay, fossa for the gallbladder as well as for the porta hepatis. In this region, we don't see the peritoneum. Rest all the surfaces are covered by the peritoneum. So now what do we see from, what are the features we see? From left to right, if you see, okay. So this is what I meant by peritoneal relation. So this is the porta hepatis. This is the ligamentum teres, hepatis fissure, and the fossa for the gallbladder where it is not covered. Okay. So here, from left to right, when we come to, okay, we see the different impressions formed by the different organs. Okay. So here, so this area, this we call it as the gastric impression. Okay. So it is a shallow concave fossa here, if you see, and this is mainly formed by the stomach. Gastric impression, as the name says, it is formed by the stomach. So stomach comes in relation to it with this surface. Then here, there is a small elevated part, which we call it as the tuber omentale. Okay, this is known as the tuber omentale. And it is a rounded elevation between this gastric impression and the lower end. So this is the fissure for the ligamentum venosum. Okay. So between the fissure for the ligamentum venosum and this gastric impression, there is a small elevated part, which we call it as the tuber omentale. Then we have the fissure for the ligamentum teres. Okay. So this is the fissure for the ligamentum teres. So ligamentum teres hepatis, okay, it is actually a remnant of the obliterated umbilical vein. left umbilical vein, obliterated left umbilical vein. And then we have here, this we call it as the quadrate lobe. So this quadrate lobe, if you see, it is quadrilateral in outline. It is bounded on the right by the fossa for the gallbladder and on the left by the fissure for the ligamentum teres hepatis. And above and behind where we have the porta hepatis. Okay, so here in this portion, it is related to the we call it as the duodenal impression, because here we have the junction that is of the pylorus as well as the first part of the duodenum comes in relation to this quadrate lobe. So next to that, here we see the porta hepatis. Okay, so this porta hepatis, it is a transverse non-peritoneal fissure here. So this is porta hepatis. Porta hepatis means like, porta means like a portal. So which is going, it is forming a gateway. Okay, so porta hepatis is also known as the gateway for the liver. Okay, so here why we call it as the gateway for the liver is some of the important vessels, they enter as well as some structures leave this liver. Okay, some enter the liver and some leave the liver. So that is why this is known as the porta hepatis. So this porta hepatis, the structures which enter here, if you see, we have the right and left branches of hepatic artery. So this is the hepatic artery, right and left branches of hepatic artery, the right and left divisions of portal vein, the hepatic plexus of nerves. So these are the structures which enter the liver. And the structures which leave the porta hepatis will be the right and left. Here you can see the right and left, say this thing, hepatic duct. Okay, hepatic duct, then which forms later the cystic duct. Okay, and lymphatics. So these are the structures which will leave, and these are the structures which will enter. So when we see these principal structures, the arrangement of the structures from before backwards, okay, so we have the ducts first, then the artery, and then the vein. So the right and left hepatic duct, the right and left hepatic artery, and the right and left portal vein. So basically this right and left portal vein or the right and left hepatic duct, they enter the physiological right and left lobes of the liver through this porta hepatis. This porta hepatis, one thing you should know is it is not a true gateway, though we call it as the gateway for the structures to enter or leave the liver. Still, we don't consider it as a true gateway. And do you know why we don't call it as a true gateway? Because if you have noticed here, the hepatic artery is entering, but hepatic vein is not coming out, isn't it? So hepatic veins do not traverse through this porta hepatis. Instead, hepatic veins open directly into this vena cava. Here you can see, okay, near the groove for the inferior vena cava. Okay, so that is why we don't consider this as a true gateway. Okay, so next after that, here we will see the caudate and the papillary process. Okay, so this is the, this is the caudate lobe. So caudate lobe will have two processes. One is the caudate process and this side we'll see the papillary process. So they are basically tail-like projections which arises from this. Okay, so and then after that, here we have the fossa for the gallbladder. Okay, this is the fossa for the gallbladder, and for which will be housing this gallbladder here. And next to that will be the duodenal impression here. Okay, so this quadrate lobe, we are at the junction of pylorus in the first part of duodenum. This is the duodenal impression, which is formed by the junction of first and second part of the duodenum. Okay, then we have the colic impression. Colic impression is basically formed by the right colic flexure. Okay, and then we have the renal impression. So renal impression is related to the anterior surface of the upper part of the right kidney. So these are the things which you need to know. Okay, so this entire surface here, what we see is the inferior surface of the liver. Okay, so peritoneal relation also. One thing which you need to know is this area which is not covered by the peritoneum. Okay, so the entire liver is covered by the peritoneum except for in the inferior surface, as I said earlier, the porta hepatis, the fissure for the ligamentum teres, and the fossa for the gallbladder. Okay, here on this posterior surface, this is known as this portion is the posterior surface. Here the bare area of the liver, the groove for the inferior vena cava, as well as the fissure for the ligamentum venosum. Okay, so here we do not see the peritoneum. So this bare area is a triangular area. Here it is bounded above by the superior coronary ligament, here the inferior coronary ligament, which will join to form the right triangular ligament. Okay, and this side it is bounded by the groove for the inferior vena cava, the base. Okay, so this area is not covered by the peritoneum. So ligaments of the liver. So the false ligaments include all these peritoneal folds, which include the left triangular ligament, the right triangular ligament here. Okay, so which I already told you, formed by the coronary ligament, superior and inferior. This is the falciform ligament. Okay, so all of these, they are the peritoneal folds. So they are known as the false ligaments. Okay. Here also you can see. Okay, so the coronary ligament, superior, inferior, enclosing the bare area of the liver. The true ligaments include the ligamentum venosum and the ligamentum teres hepatis. Okay, so ligamentum venosum, it represents the ductus venosus. Okay, in the fetal life, and ligamentum teres hepatis, it represents the left umbilical vein. Okay, so these are the things which you should know. Okay, so when we talk about the inferior surface of the liver, so inferior surface of the liver, the important things which you have to, impressions which you have to know is the inferior surface. Two things are important there on the inferior surface of the visceral surface. One is the peritoneal relations, so which is not covered basically there, because the entire surface is covered except for three portions. Peritoneal relations, okay, not peritoneal surface, peritoneal relations here. So we see in three areas which it is absent, that is porta hepatis. Okay, porta hepatis, then the fossa for the gallbladder. Okay, fossa for the gallbladder, as well as for the, we don't see it in the ligamentum, fissure for the ligamentum teres hepatis. Okay, so three areas we don't have the no peritoneum here. Okay, then you have to talk about all the impressions. Okay, so impressions, when we talk about from left to right, when we go, we have the gastric impression. Okay, then we have the pyloric, that is pylorus plus first part of duodenum. Okay, then we talk about the fossa for the gallbladder, where the gallbladder is there. Okay, then we have duodenal impression formed by the junction of first and second part. Okay, so first and second part of duodenum junction. Then we have the colic impression and renal impression. Colic impression formed by the right colic flexure, and renal impression formed by the anterior surface of the right kidney. In addition to that, you have to talk about porta hepatis as well as the fissure for the ligamentum venosum. So these are the features which you see on the inferior surface of the liver. Okay, so that is what it is. So next is extrahepatic biliary apparatus. Okay, so what do we mean by extrahepatic biliary apparatus? Now, biliary apparatus as such, okay, it includes the passages through which the hepatic bile as well as the biliary bile, that is from the gallbladder bile. Okay, so gallbladder bile, they are conveyed to the second part. So if you see here, okay, so from the from the liver, that is hepatic bile, and from the gallbladder bile. Okay, how it will reach the second part of the duodenum. So whatever passages are there for the flow of this bile, we call it as the biliary apparatus. Now basically this biliary apparatus, we have the intrahepatic and the extrahepatic. We are dealing with extrahepatic. So intrahepatic is basically the structures present within the liver, which include the bile canaliculi, canals of Herring, bile ductules, right and left hepatic ducts. So from then onwards will be the extrahepatic biliary apparatus. Okay. So here we should know what do we mean by this biliary apparatus, where it is the location of these structures, as well as what are the components of it, the features of those components, okay, and the blood supply of gallbladder, nerve supply, as well as some the applied aspects. So components of the extrahepatic biliary apparatus, it includes the hepatic ducts, right and left hepatic ducts, okay, the common hepatic duct, the gallbladder, okay, the cystic duct, and the common bile duct, okay. So these are the structures which form the components of the extrahepatic biliary apparatus. Okay, so first coming to these hepatic ducts, okay, which form the common hepatic duct. So basically, the common hepatic duct here is formed by the union of the right and left hepatic ducts, which begin from the liver. So right and left hepatic ducts will drain the right and left physiological lobes of the liver, and they will drain the bile into they join together and form the common hepatic duct. Okay. So this common hepatic duct, if you see, it is about 3 centimeters long and about 4 millimeters in the caliber. It measures about 4 millimeters in the caliber. So basically, this is related to the portal vein. Okay, so behind this hepatic duct will be the portal vein. And on the left side, we will see the principal hepatic artery, and below we will see the cystic duct. Okay, this is the cystic duct. So these will be the relations of this common hepatic duct. Okay, here you can see. So this is the common hepatic duct. So behind you are seeing the portal vein. Okay, this is the portal vein. On the left side, we are seeing the hepatic artery. And this side, below and to the right, we are seeing the cystic duct. So they form the relations of the common hepatic duct. So next we will study a little bit about the gallbladder. So what is this gallbladder? Okay, so it is a pear-shaped, hollow, viscous, and it is slate blue in color, okay, normally. And it is obliquely placed. It's in a fossa for the gallbladder on the inferior surface of the liver, okay, right lobe of the liver. It extends from the right end of the porta hepatis. So if you see, it extends from, this is the porta hepatis here. So from the right end of the porta hepatis up to this border here is the inferior border of the liver. So it will extend up to that inferior border of the liver. So this gallbladder, it measures about, okay, so if you see the gallbladder, it measures about 7 to 10 centimeters in length. Maximum breadth, it includes about 3 centimeters, and capacity is about 30 to 50 ml. So that is the capacity. So when we see the presenting parts, the gallbladder will have from below upwards, if we come, it has a fundus. Okay, this is the fundic portion. It has a body and it has a neck. So fundus here is the expanded portion. Okay, so fundus here, if we see, is the expanded free end of the gallbladder, which projects below the liver. So this is covered by the peritoneum on all the sides. And next we have the body. So the body extends from the fundus up to the neck, and it is direct upwards, backwards, and to the left. If you see, okay, upwards, backwards, and to the left it is directed. So this upper surface of the body here, in the upper surface, it is non-peritoneal, and the lower surface as well as the sides are covered by the peritoneum. Okay, and next we have the neck. So the neck is an S-shaped curve. Okay, it is an S-shaped. If you see here, it forms an S-shaped curve and extends from the body up to the cystic duct. So here, if you see, the neck passes upwards and forwards, and then it turns. Abruptly, it turns downwards and backwards. Okay, and it is continuous with the cystic duct. Okay, this is the cystic duct, which is separated by a constriction here. So from the neck, okay, so from this neck, if you see, there is one pouch here, a small diverticulum. Okay, this is known as the Hartmann's pouch. So this projects, okay, so usually you can see this Hartmann's pouch, which will be projected downwards and backwards towards the duodenum. This is the duodenum here. So you will see towards the duodenum. So the portion of the neck giving attachment to this Hartmann's pouch is sometimes called as the isthmus of the gallbladder. Okay, so this is known as the isthmus portion of the gallbladder. Okay. So basically, what does this gallbladder do? It stores and concentrates the bile, okay, about 10 times more than the liver. Okay, so as well as it will reduce the alkalinity. Okay, it's alkaline nature of the hepatic bile. It will reduce and it will equalize the ductal biliary pressure. So that is why from the liver, it is stored in the gallbladder. It goes to the gallbladder. Okay. So though we do cholecystectomy where we remove the gallbladder, it doesn't affect much of the function because liver will not cause any dysfunction just because we remove the gallbladder. Okay, that is one thing you need to keep in mind. So arterial supply. So what is the cystic artery? Okay, cystic artery supplies the gallbladder. The blood supply to the gallbladder is by the cystic artery, which is derived from the right branch of the hepatic artery. Okay. So cystic artery will divide into superficial and deep branches close to the neck and it will supply the gallbladder. Venous drainage is usually cystic vein. Okay, so this cystic vein, it will drain into the directly into the intrahepatic part of the portal vein. Lymphatic drainage is mainly into the hepatic group of lymph nodes which are situated close to the porta hepatis. Okay. So nerve supply. So nerve supply is via the cystic plexus, which are formed by the sympathetic fibers from T7 to T9. So parasympathetic supply is by the right and left vagus nerve and the fibers of the right phrenic nerve. Usually this pain is referred, okay, so gallbladder pain, because of this nerve distribution, it is referred to the back, okay, it is referred to the shoulder, right shoulder, okay, as well as in the abdomen. We can feel that is there on the epigastric region. The pain is felt, gallbladder pain can be felt. Next, you have to know about the cystic duct. So this is the cystic duct. Cystic duct, if you see, it measures about 3 to 4 centimeters in length and is about 2 millimeters in caliber. So if you see, it begins from the neck of the gallbladder, passes downwards and backwards and to the left and ends by joining the right common side, okay, the right side of the common hepatic duct, okay. So this interior of the cystic duct, if you see here, interior is interior presents about 5 to 12 precentric valves. Okay, these are the valves, precentric valves, which are known as the spiral valves of Hester. Okay, spiral valves of Hester. So spiral valve of Hester it is called. Okay. Spiral valve of Hester. So why do we have this is because these spiral valves, they make the lumen patent, okay, so that the lumen doesn't collapse. So the spiral valves are usually found only in man and primates, okay. Primates we see these spiral valves. Okay. Next, we have the bile duct. Okay, so the bile duct, which otherwise we call it as the common bile duct, it is about 7.5 centimeters long, about 6 millimeters in caliber. Okay, so it is formed close to the porta hepatis by the union of the common hepatic duct and the cystic duct. They join to form this common bile duct. So from its formation, the bile duct will pass downwards, backwards, and slightly to the left within the free margin of the lesser omentum. Here, no, we will see the lesser omentum. So along the free margin, it will run. Okay. Then it runs in front of the epiploic foramen and then descends behind the first part of the duodenum, lodges in the groove behind the head of the pancreas here. Okay. And then it will open, okay, into the Okay, or sometimes not only it just lodges behind, sometimes it even passes through the substance of the head. And in the posterior medial wall of the second part of the duodenum here, the bile duct comes in contact with the main pancreatic duct. So this is the main pancreatic duct, okay? And these both the ducts will pierce the duodenal wall separately, and after they pierce, okay, they unite to form the terminal dilated part, which we call it as the ampulla of waters. So first thing is they pierce separately, both the pancreatic duct as well as the bile duct. After piercing, they form a common dilated part, which we call it as the ampulla of water. The constricted end of the ampulla here, this is the constricted end. It opens on the summit of the major duodenal papillae. So this major duodenal papillae is situated about 8 to 10 centimeters distal to the pylorus. So from the pylorus, it will be at a distance of 8 to 10 centimeters. Okay. So here, so this common bile duct here, we have three parts. That is the supraduodenal part, the retroduodenal part, and the pancreatic or infraduodenal part. Okay, the supraduodenal part is about the first part of the duodenum. So this is related. Okay, here it will be related to the portal vein behind, and on the left side there will be the trunk of the hepatic artery. Okay, this is the hepatic artery. So it is related to the trunk of the hepatic artery. Then the retroduodenal part, which is lying behind the first part. Okay, so in front it is the duodenum. Behind will be the portal vein. Okay, and on the left side will be the gastroduodenal artery. Okay, left side gastroduodenal artery. Then infraduodenal or the pancreatic portion below. So in front it will be the head of the pancreas here. Okay, as well as accessory pancreatic duct and all. Behind will be the posterior row of vasa recti, inferior vena cava will be present. Left side, on the left side, it is related to superior mesenteric and portal veins. Then a small portion is this intraduodenal part. So that is only about 2 centimeters. Okay, and the ampulla measures about 5 millimeters in breadth. So these are the things which you should know. So this is here, you can see how it is forming. Okay, this was the supraduodenal, this is retroduodenal, this is infraduodenal or pancreatic portion. Okay, so this bile duct, this consists of sphincters, okay, 3 sets of sphincters. So these 3 sets of sphincters, we call it as sphincter choledocus, sphincter pancreaticus, and sphincter of Oddi, okay, or proper sphincter. So sphincter choledocus is around the preampullary part of the bile duct, okay. This is sphincter choledocus or sphincter of Boyden, it is also called as sphincter of Boyden. Sphincter pancreaticus is around the preampullary part of the pancreatic duct, and sphincter of Oddi is around the terminal portion of the ampulla, okay, termination here of the ampulla. So of this, among all this, the sphincter of Boyden is very strong, whereas the others, so this is all your MCQ questions, okay, the sphincters, which is the strongest sphincter, what is sphincter of Oddi and all those things, okay. So sphincter of Boyden is the strongest of all, and other 2 sphincters are present only in, it may not be there always, okay, so it may be present only in about 1/6 of the population, okay. So the blood supply. So upper part of the duct is supplied here. Upper part of the bile duct is supplied by the cystic artery. Middle part by the hepatic artery. So that is why this bile duct blood supply is important, because the different portions are supplied by the different arteries. Okay, so that is why it is commonly asked. So as an MCQ question also it is asked. Okay, so upper part is by the cystic artery. The middle part is from the right hepatic artery, and the lower part is supplied by the posterior superior pancreatico-duodenal artery. Posterior superior pancreatico-duodenal artery. Okay. Here, one of the important thing you need to remember is about the Calot's triangle. Okay, this is the Calot's triangle or cystohepatic triangle of Calot. So it is a 3-mark question, or what are the content, it can be asked as an MCQ question. So it is a roughly triangular space bounded inferolaterally. So here inferolaterally it is bounded by the, so if you see here, inferolaterally it is bounded by the cystic duct, superolaterally by the inferior segment of the, okay, liver. Okay, this inferior surface, okay, superolaterally, and medially by the common hepatic duct. So this is the triangle, okay, so it is enclosed by the double layer of peritoneum, which acts as a mesentery of the cystic duct. So why this Calot's triangle is important is it contains the cystic artery here, okay, cystic artery, and 1 or 2 small cystic veins, as well as the cystic lymph node of Lund, okay. So these are present there. Next is a common condition which we see with the gallbladder is basically the gallstones, okay, inflammation of the gallbladder is known as cholecystitis, and this is cholelithiasis when we have the stone. So usually there will be a lot of pain, and it is referred to the tip of the shoulder as well as back region, okay. So it is associated with the symptoms which we see are jaundice, nausea and vomiting, poor appetite, anorexia, fat intolerance, feeling of fullness, abdominal distension. Okay. So in the right upper quadrant on right shoulder, you may feel the pain. So risk factors for gallbladder. Okay. Common risk factors, we say 4 Fs. That is fat 40 female, fertile female. Okay. Fat 40 fertile female. So they are at higher risk. Anybody can get a gallstone, but these people are at higher risk. So the biliary colic is basically because of the spasm of the smooth muscles of the gallbladder. It is intermittent. It just comes, goes like that, okay? And when the calculus is impacted at the terminal end of the cystic duct or at the lower end of the common bile duct, the pain becomes very intense, okay? The pain is very intense then. And referred pain is felt in the right upper quadrant of the epigastrial region. And sometimes these stones can also cause obstruction, okay, obstruction, and that can lead to obstructive jaundice also. This is how we do imaging techniques, and in imaging, this is how the gallbladder will look, okay. This is in the ultrasound. This is in a contrast study. So this is commonly done endoscopic retrograde cholangiopancreaticography. So through the endoscope, retrograde cholangiopancreaticography means what is done, endoscope is passed and retrograde. So from the ampulla of water, the dye is pushed and we see, okay. So if there is any obstruction, so you can see it is tracing almost here, everything is normal. Up to the liver, we can see the tracing here, okay. Here even in the pancreas, the duct is all normal here. So this is known as endoscopic retro, ERCP, commonly said, endoscopic retrograde cholangiopancreaticography. Other thing is PTHC, that is percutaneous transhepatic cholangiography. So here what happens is through the skin, okay, through the skin, percutaneous as the name says, through the skin, and through the liver. That is usually the right lateral side we use because that is in more contact with the abdominal wall. So from there we pass, a needle is passed into the liver and then the dye is injected. So it is taken up here and you can see. So here there is a little bit of narrowing down here. Okay, so these are the things. So you have to know what do we mean by extrahepatic biliary apparatus. Okay, extrahepatic biliary apparatus means what? What are its components? Okay, and you have to know important thing is the gallbladder, the parts in gallbladder. You should know about its parts. What are its parts, which is commonly asked. Then you have to know about the common bile duct. Okay, its course and relations. Okay, the three parts of it. And then we need to know about the sphincters. Okay, and the blood supply of common bile duct. Okay, as well as you have to know the applied aspects. Then in additional to this, you should know what is Calot's triangle. So Calot's triangle, sometimes the cystic duct will form a loop, which is called as the Moynihan's hump. Okay, so that is also commonly asked as a MCQ question. So these are the headings under which you need to explain the extrahepatic biliary apparatus. So it is commonly asked as a long essay question. We move on to the next question, that is kidney. Okay, so in the kidney, what are the things we should know? Okay, so what is kidney? Where are they located? And relation, structure, blood supply. Okay, surface marking of it is very little important. So what are kidneys? Now, kidneys are a pair of excretory organs, isn't it? Excretory organs. So basically, they excrete the urine and eliminate the nitrogenous waste, okay, as well as products of protein metabolism. In addition to that, they also maintain the electrolyte and water balance, okay? And they secrete some of the hormones. That is, it secretes renin, which is responsible for autoregulation of the blood flow and blood pressure, erythropoietin for the maturation of red blood cells, and 125 hydroxycholecalciferol for the control of calcium metabolism. So those are commonly asked as an MCQ question. Okay, these hormones which are produced by the kidneys. So where is this kidney situated? The kidney is situated retroperitoneally in the posterior abdominal wall by the side of the vertebral column. Okay, so if you see, it is situated by the side of the vertebral column in relation, okay, to from T12 up to L3. So right kidney is slightly lower compared to the left kidney because of the presence of the liver. Left kidney is longer and narrower, and it is more closer to the vertebral column compared to the right kidney. Okay. So the long axis of the kidney, when we say, it is directed downwards and laterally, so that the upper end is closer. Okay. So if you see, the upper end is closer to the vertebral column, whereas lower end is away from the vertebral column. So each kidney, it measures about 11 centimeters in length. Breadth is about 6 centimeters here, 11 centimeters in length. Breadth is about 6 centimeters and thickness is about 3 centimeters. And it weighs about 150 to 170 grams in males, and in females about 130 to 150 grams. Okay. So here, if you see the upper pole, it is about 2.5 centimeters from the vertebral column. The hilum is about 5 centimeters, whereas the lower pole is about 7.5 centimeters. So here, each kidney will have an upper pole, a lower pole, okay, an anterior surface, and behind will be the posterior surface, a lateral border, and a medial border. Medial border consists of the hilum, where the structures enter and leave the kidney. Okay, so at the hilum, the arrangement of structures from anterior to posterior, we have the renal vein, the artery, and the renal pelvis. Okay, so sometimes an additional branch of renal artery can also be seen behind the renal pelvis, but usually we see renal vein, renal artery, and the renal pelvis. With this, we actually identify the side to which it belongs to also, okay, based on the arrangement and the appearance. So, okay. So coming to the relations. So anterior relations here of the right and left kidneys is slightly different. So on the right side, if you see, we have near the upper pole, we have the suprarenal area where the right suprarenal gland is located. Okay, near the hilum, we have the duodenal area where the duodenum comes in relation. This is hepatic area where we have the liver in relation to that. Okay, and then below that, here we have the colic area. Below the hepatic area, we have the colic area where the right colic flexure comes in relation. And this is the jejunal area where the coils of jejunum are in relation to the lower pole. Whereas on the left side, we have the suprarenal area where it is related to left suprarenal gland. Below that, there is gastric area. And behind will be the splenic area where spleen is in relation. Here, stomach is in relation in the gastric area. Then pancreatic area opposite to this hilum. And then below colic area where we have the left colic flexure and this is the colic area, and this blue thing is the jejunal area with coils of jejunum are present. Posteriorly in the upper part, it is related to the 11th and 12th ribs as well as to the diaphragm. Okay, so 11th and 12th ribs and the diaphragm. Below that, okay, it is related to, if you see from the medial to lateral when we go, psoas major muscle is there. Then we have the quadratus lumborum muscle. Then we have the subcostal nerve, the iliohypogastric nerve and the ilioinguinal nerve, both on the same relations we see on either side. This is left kidney. On the left kidney, we see 11th rib because it is slightly higher. This is slightly lower, so we see only 12th rib. That's the only difference. Then we have the subcostal vessels and nerves in relation. Okay, so those are the relations of right and left kidney. Then the coverings. The coverings of the kidney include 4 things. One is the fibrous capsule here, that is, which is covering the kidney, which we call it otherwise called as the true capsule. Then around that, there is the perinephric fat. Okay, this is the perinephric fat here. Okay, which forms a fatty covering for that. Then there is the renal fascia. Outside to that, there is renal fascia. Okay, which forms the false capsule, otherwise called as the fascia of Girotta. And around that will be the paranephric fat. So 4 layers. Okay, so fibrous capsule, which is the true capsule, then perinephric fat, renal fascia, and the paranephric fat. So here, if we see this renal fascia, the tracing of the renal fascia is a little important. So laterally when we trace it, okay, so laterally when we trace the renal fascia here, both layers are fused at the lateral border of the kidney and are continuous with the fascia transversalis. Okay, so here both at the lateral border they fuse and they become continuous with the fascia transversalis. So medially the anterior layer, so this is the anterior layer, so it covers the front of the kidney and the renal vessels and is continuous with a similar layer of the opposite side. Okay, opposite side in front of the aorta and the inferior vena cava. Posterior layer here, it covers the back of the kidney and the renal vessels and it blends with the psoas fascia and is attached to the body of the lumbar vertebrae. So this is the psoas major, fascia covering that is the psoas fascia. So it blends with that and it becomes, it is attached to the bodies of the lumbar vertebrae. Okay. Then above, now here above, that is at the upper pole, both of the layers, that is the anterior and the posterior layer will fuse at the upper end of the kidney. Okay, that is at the upper pole. And again, they will split to enclose the suprarenal gland. So the upper end of the suprarenal gland, again, they will unite and are continuous with the diaphragmatic fascia. Okay, subdiaphragmatic fascia forming the suspensory ligament. So this is called as the suspensory ligament of suprarenal gland. Then because of this separation here, when the kidney descends down, downward displacement of the kidney occurs, this is not descends down along with the kidney, okay, because this has a separate covering. Below the 2 layers here, they do not fuse. Instead, they extend downwards, okay, downwards along the ureters, and finally they just get mixed with this, lost in the extraperitoneal tissue of the iliac fossa. Okay, so that is about this tracing of the renal fascia. So the structure of the kidney. So when we see the structure of the kidney, it mainly consists of macroscopically 2 parts. Okay. So outer renal substance, this is the renal substance, which we call it as the kidney proper, and inner renal sinus. So this renal substance consists of 2 areas, the cortex and the medulla. So here you should know what is present in the cortex. Okay, cortex and the medulla. So in the medulla, when we see, it has about 8 to 10 renal pyramids. Okay, these are called the pyramids. Okay, here. So it consists of these renal pyramids. which are striated, pale, and conical masses. So each of the pyramid will have a base which is directed to the cortex and an apex which is directed towards the renal sinus. Okay, and that is known as the renal papillae. So this one renal pyramid, which is capped by the adjoining cortex, we call it as the lobe of the kidney. Okay, one renal, that is pyramid with the cortex, we call it as the lobe of the kidney. So in the nephron here, when we see the glomerulus, the Bowman's capsule, okay, the proximal convoluted tubule, the distal convoluted tubule, okay, a small portion of the collecting duct is seen in which one? The cortex. Whereas the descending loop of Henle, okay, the loop of Henle, the ascending loop of descending limb of Henle, the loop of Henle and the ascending limb, okay, the loop of Henle. So this, as well as the collecting tubules, we see it in the cortex. Medulla. Okay, so this is the collecting duct of Bellini called. So this is what you need to know here. Okay, the renal sinus here, it is a cavity within the kidney and it communicates outside through the hilum. Okay, so the renal sinus consists of renal blood vessels, lymph vessels and nerves as well as perinephric fat. So the renal sinus will lead to the renal, the calyces, okay, minor and major calyces, and calyces will lead to the renal pelvis. The blood supply of the kidney. Okay, so blood supply of the kidney here, we should know that it is by the renal artery. Okay, so the renal artery, what happens is, it divides into anterior and posterior divisions. And each of these divisions will divide into segments. Okay, so it goes to each segment. So we have the 5 segments here. Oh, sorry, 4 segments, 1, 2, 3, 4 segments. Okay, so it divides. So it, in front of this, so this is that the hilum. No, hilum, what happens is the renal artery, it reaches up to the hilum of the kidney between the renal vein in front and the pelvis of the ureter behind, and it divides into these anterior and posterior segments. So the anterior trunk, it passes in front of the, so if you see, it is passing in front of the renal pelvis and divides into 4 segmental arteries, that is apical, upper, and anterior, upper and anterior, middle and inferior. Okay, upper anterior, middle and inferior anterior. Okay, so it divides into 5 segments and it is continued as the posterior segment. Okay, behind it will be continued as the posterior segment. Now this the segmental arteries, what happens is, so if you see here, each of these segmental arteries, they divide into lobar branches, means they go to each lobe of the kidney. So each lobar artery, before it pierces the kidney substance, divides into 2 interlobar. Okay, 2 interlobar arteries. It passes through these renal columns between the adjacent pyramids. And at the junction of the cortex and the medulla, the interlobar artery will divide. Okay, into arcuate arteries. Okay, so these are called as the arcuate arteries. So arcuate arteries, they do not anastomose with each other. So from these arcuate arteries, what happens? Many interlobular arteries, okay, interlobular arteries will arise. And these interlobular arteries will ramify beneath the capsule to form a subcapsular plexus. So these are the subcapsules. This is the renal capsule. So below that, they will ramify to form the subcapsular plexus. Okay, so each of these interlobular artery will give origin to these efferent arterioles, glomerular arterioles. So here you should know posteriorly, okay, so posterior also it will divide, supplying these segments, but at the junction of on the posterior surface, at the junction of the medial 2/3 and the lateral 1/3, what happens is there is a plane, which we call it as the avascular line of Brodel. Okay, so here what happens is there are anterior and posterior segmental arteries, they do not anastomose. So this area is relatively has lesser blood supply. So this is used as a surgical site to approach the liver, the kidney. Okay. So these are the segments, arterial segments, apical, upper, middle, and lower. This is anteriorly, this is posteriorly, apical, posterior, lower. So this apical, upper, middle, and lower, they are supplied by the anterior segmental only, whereas the posterior segmental branch will supply the posterior part. Okay, so those are the segments. So surface marking, so this is what we call from the posterior, on the posterior abdominal wall, we mark the kidney, okay, through what we call it as the Morris parallelogram. So at the level of T11 spine of T11, we draw a horizontal line, okay, and we draw one more horizontal line at the level of the spine of L3, okay. So this is about, each horizontal lines will be about 9 centimeters in length. Then we draw a vertical line. So first vertical line we draw at about 2.5 centimeters from the median plane. Okay, and the second vertical line will be about 9 centimeters from the median plane. So like that, two vertical lines we draw. Okay, and we join all those, the upper two horizontal lines and these vertical lines, and what we get is the Morris parallelogram. Okay. So here, when we draw the kidney, with the upper pole towards the median plane and lower pole away from the median plane. Okay, so this will be about 2.5 centimeters. This will be about 5 centimeters. And this will be, lower pole will be about 7.5 centimeters from the median plane. Okay, so these are the things we need to know, especially about kidney. The important things which you have to know is the coverings, okay, then the tracing of the renal fascia, okay, tracing is very important. It's commonly asked as a 3-mark question or sometimes even as a 5-mark question. Then the anterior and posterior relations of the kidney, okay, and then we have what we call it as blood supply, okay. So blood supply is important, okay. So these are the things which you have to know about the kidney. And the surface marking. Another one is the surface Morris parallelogram. It is asked as a 3-mark question. Coming to the short answers. So we'll go study about the development of kidney. So development of kidney, we have to know what is the embryological source for the development, what are the stages of development, and the anomalies associated with the development. So in the development of kidney, we say ontogeny repeats phylogeny. Okay, that means we see the evolutionary kidneys, all the 3 levels of evolutionary kidneys, okay, in the development of the kidney. So our kidney is the metanephric kidney. Okay, so during the process of the metanephric kidney, we see the different other stages, that is the pronephric as well as the mesonephric kidney. So now the first step in the formation of this kidney is formation of the urogenital ridge. Okay, urogenital ridge. So this is formed from the intermediate mesoderm. So this intermediate mesoderm initially forms the urogenital ridge. And this urogenital ridge will differentiate into 2 areas. That is, the medial will form the genital ridge from which the gonads will be developed, whereas the lateral part will form the nephrogenic cord from which the kidneys will be developed. Okay, the urinary system will be developed. So the first step in the nephrogenic cord, okay, so what happens is in the, so it will extend all the way from the cervical up to the sacral region, it will be extending, okay. So in the upper part here, what happens, each of this developing kidney will have the tubules which develops, okay. So they are known as the pronephric tubules and the pronephric duct. So initially this stage here, when we see, Okay, the pronephric duct and the pronephric tubules. This is the pronephric tubules which are coming from the pronephros. Okay, so that will form. But this is not enough for the functioning. Okay, so what happens is it will degenerate. And the next stage, that is the mesonephric. So the pronephric tubules as well as the pronephric duct, the upper portion will disappear, degenerate, whereas the lower portion will continue as the mesonephric duct. Now, this portion of the nephrogenic cord will differentiate into segments forming the mesonephris, and each will have its own tubules. Okay, these are known as the mesonephric tubules, which will be opening into the mesonephric duct. And this mesonephric duct will open into the cloaca. Okay, so this will be opening into the cloaca, upper part of the cloaca, which we call it as the vesico-urethral part of the cloaca. Okay. So this is the mesonephros part. So it is opening here. So if you see the difference in the upper part here directly, it is opening into the peritoneum. This is called as the external glomerulus it will be having. Okay. Here we have the internal glomerulus where a little bit of what happens in our kidneys, the metanephric, the filtration will be happening, but all the absorption will not be happening. So it progresses to the next stage of development. Okay. So here we have that. So this mesonephric duct will open into this vesico-urethral part of the cloaca. So here what happens is this portion, a small portion from the mesonephric duct, it will form a small bud. Okay. So this bud, we call it as the ureteric bud. It is known as the ureteric bud. And the lower portion of this nephrogenic cord, they will form a solid mass of cells, which we call it as the metanephros. So next step, what happens is this ureteric bud. Okay, so the ureteric bud, it will divide into, it will go on dividing into 13 generations of divisions, which we call it, by which it forms the major and minor calyces. Okay. So major and minor calyces. So the entire collecting system of the kidney. Okay. So the kidney will have two parts. One is the excretory part. Another part is the collecting part. So the collecting part is formed by the ureteric bud. Okay. Which has developed from the mesonephric duct. So just before it opens into the that is the vesico-urethral part of the cloaca, this would have given a mesonephric duct. So this will divide into many generations, forming the entire collecting system of the duct. Now, on the surface of each of these divisions, okay, this metanephric, metanephros, it will deposit, like it will form what we call it as the metanephric blastema. Okay. So once the metanephric blastema is formed, so on each of these divisions, here you can see this metanephric blastema comes in relation. Okay. So from this ureteric bud, we have all the collecting tubules, collecting ducts, minor calyces, major calyces, renal pelvis, ureter. All of them derived from this entire ureteric bud. Now this metanephric blastema, what happens with that? We'll see. Okay. So this is how it will form. The remaining portion of the mesonephric duct which will join together to form that trigone. Okay, trigone of the bladder. So now this metanephric blastema, they are the cell clusters which will be capping over this collecting part. Okay. So here what happens, this metanephric blastema first forms a vesicle like. Okay. This is called as the renal vesicle. Okay. So from there what happens is, next is at this where it is little bulging, it will form a U-shaped, a cup-shaped, okay, a shaped renal vesicle it forms. So this renal vesicle then with further development forms a S-shaped one where it forms the Henle's loop. So where it is formed that U-shaped, cup-shaped mass, here what happens, the blood vessels will communicate there. Okay, the blood vessels will infiltrate, which forms the efferent and afferent vessels. And this forms what we call it as the glomerulus. So this initial portion forms the proximal convoluted tubule. Then we have the loop of Henle and the limbs of Henle, and then the distal convoluted tubule, and this portion becomes the collecting duct. So from each of this is nephrons will develop. Okay, so nephrons is the excretory part. So from the metanephric blastema, the excretory part, which we call it as the nephron develops. Okay, so that is how the kidney develops. So kidneys, since we saw it in the nephrogenic cord, okay, so first was pronephros, then metanephros and mesonephros. So that was almost in the, mesonephros and then metanephros. So metanephros was in the pelvic region, almost in the same pelvic region. Okay, so the kidney first develops here. Later on, it ascends upwards. Okay, so with the further uncurling of the fetus as well as the development of the abdominal walls, what happens is it will go on ascending. It goes to the iliac fossa, then goes to the posterior abdominal wall to its normal position. Okay, so initially the hilums will be facing forwards, okay, before rotation. Later on, what happens? They face medially. Okay, they will be facing medially. So sometimes abnormal rotation can happen where the one of the kidneys may rotate laterally, the hilum may face laterally itself. Okay, or here also where it will wind around all the way, it will wind around the artery and then open into the hilum. Sometimes one of the kidney may not develop, or there will be multiple kidneys. Okay. Then fused kidney. So the kidney can get displaced and both the kidneys may be fused. Okay. And sometimes one of the kidney may just remain in the pelvis itself. It may not ascend. We call it as the pelvic kidney. Sometimes these lower poles. Okay. So lower poles during the development may approximate each other and they may fuse. Okay. And that is known as the horseshoe-shaped kidney. And sometimes the entire, both the right and left kidneys may fuse and form a disc-shaped kidney. Okay, so these are all developmental anomalies. Okay, so even the ureters also, there may be double ureters, and sometimes the mass doesn't develop. Instead, there will be a lot of cysts within, which we call it as the polycystic kidney. So before loop formation, we have this. Okay, so the loop it forms and then it fuses to form the tricone as well as then the ureter opens here. This is the loop which is formed. Okay, so sometimes the kidneys will have double ureter or it may be two ureters. So this can also happen. Floating kidney, where there is kidney is not fixed and it can move easily. Okay, move easily and it can cause kinking of the pelvis. So these are some of the abnormalities. Okay, so when we know about kidney development, okay, the development, we need to know development, the three stages. Okay, the pronephros, the meso, and the metanephros. Okay, and we have the metanephric kidney. So here you have to know the collecting part. Kidney will have the collecting part and the excretory part. So collecting part developed from the ureteric bud, which is formed from the mesonephric duct, whereas the excretory part is formed from the metanephric blastema. Okay, so these are the things which you should write about, and of course the anomalies. Okay, so next we will talk about the derivatives of mesonephric and paramesonephric ducts in males and females. So basically here you need to know which are the structures which are derived. Okay, so we have two ducts which are developing, mesonephric and a parameso. So mesonephric we knew that is from which one? It is forming from these tubules, isn't it? That is the mesonephric duct which is being formed. Okay. Then there is one more duct which we call it as the paramesonephric duct. So it is basically formed from the coelom. Coelom diverticulum forms and that forms a duct. So since it is situated next to the mesonephric duct, we call it as the paramesonephric duct. So mesonephric duct is otherwise called as the Wolffian duct, whereas the paramesonephric duct is known as the Mullerian duct. Okay. So here you have to basically know what are the structures which are derived from these mesonephric and paramesonephric duct. Okay. So basically, they contribute to the development of the urogenital system there, right? So we will see. So this is how initially both the ducts are there. So depending upon whether the fetus is going to be a male or female, one of the ducts will be well developed, leading to the structure. So if it is male, the Wolffian duct will develop well. If it is a female, the Mullerian duct will develop well. Okay, so the different structures will be derived. So in the male, mainly it is the Wolffian duct. So we can see the epididymis is formed, the efferent ductules. Okay, so the mesonephric tubules will form the efferent ductules. Then the head of the epididymis, the duct of the epididymis, the vas deferens, okay, the seminal vesicles, and up to the ejaculatory duct. So these many structures are derived from the mesonephric duct. Okay. Whereas the paramesonephric duct here, it will form the fallopian tube, the uterus, okay, as well as the upper part of the vagina. So those are the structures derived. So these two ducts I told you. So this is the mesonephric duct. These are the mesonephric tubules, which will open into the cloaca. This is the paramesonephric duct. Okay, this one. So derivatives of mesonephric duct in males, you can see that is the vas, that is the efferent ductules of the testis. The efferent ductules itself forms the head of the epididymis, right? Then we have the duct of the epididymis, the vas of the epididymis. Then we have the seminal vesicles, the ejaculatory duct. Okay, so these are the structures which are derived from the mesonephric. And the vestigial remnants of this mesonephric duct and tubules, they form the appendix of the testis. Okay, then the paradidymis here, and superior aberrant ductules and inferior aberrant ductules. So these are the remnants of it, okay, which are derived from the mesonephric duct. So in females, the mesonephric ducts will form what we call it as the epophoron, paraoophoron, and the Gartner's duct. Okay, epophoron, paraoophoron, and the Gartner's duct will be formed by the mesonephric ducts in females. Okay, so basically there we do not, it doesn't develop, right? So we'll see only these remnants, epophoron, paraoophoron, and the Gartner's duct. Paramesonephric duct develops well in females. So with the paramesonephric duct, if you see here, okay, so paramesonephric duct in males, what happens is it is degenerated completely. Okay, so you can see here it degenerates. It is only it forms a small portion of appendix of the testis, the paramesonephric. Okay, here. And the mesonephric duct in this paramesonephric duct in females, already I told you, it forms the, what is that? The fallopian tubes, the uterus, as well as the upper part of the vagina. Okay. And paramesonephric duct, two things. One is the appendix of the testis. Another one will be the prostatic utricle. So two structures are derived from this paramesonephric duct in males. Okay, that's it. So these are the things which you need to know. Okay, mesonephric duct, what are the derivatives, and paramesonephric duct, what are the derivatives? Okay, and the remnants of it, structures derived and the remnants, what they form. Right? So with this, we finish today's class. Thanks for watching. You can download the app and start your journey on, you can get the app on Google Play and App Store. Okay. As well as you can follow the contents, the social media contents on YouTube, Instagram, Facebook, and Telegram. Okay. So until next, see you. Bye.